Sure. Well, thank you very much to all our speakers. And look, I think that what you've seen today is really the demonstration of the emergence of initial results from this comparative modelling exercise. And so, as you've seen from the results from SysNet presented by Emily and the results directly from the CCGMC presented by Megan, by bringing together these established modelling platforms, there's been relatively rapid efforts to look at various scenarios for disruptions. But I think in fact, the explicit intent in running a session at this meeting was to seek the input of all of you present as experts in HPV. And particularly, I think we're soliciting input as to the particular scenarios that should be prioritised for looking at disruption impacts, the types of recovery prioritisation criteria that might be important. You've heard about some initial efforts to use age. Should we be looking at screening history? Should we be looking at other sorts of information about women to prioritise recovery? And then also, what should be the focus on silver linings? How should, for example, self-collection be used? How could it be accelerated as a strategy to recover from screening programs? And then finally, maybe what are some of the questions that you might be interested in around finding better value or better efficiencies in existing systems? So one example, I guess, would be the potential for the pandemic to drive a move towards sole primary screening with HPV as opposed to co-testing with cytology and HPV, in a resource-constrained environment. So we're looking not only for questions to the panel, but also for suggestions for priority evaluations. So maybe just to kick us off, Freddie, we'd ask the panel to reflect on a couple of points. The first is what data needs do we have to inform modelling of COVID impact and optimal recovery strategies? And perhaps if our panel could comment on, in 7 months into this exercise and to the pandemic, where have data proven to be available and where have been the difficulties? Where are the current evidence gaps and what are the needs from a data point of view? So I'll open that up to any of our panel members to comment on that point.
I might just comment on behalf of the US. When we're trying to project potential impacts on cervical cancer, we're faced with so many variations in state and local mandates. So I think the number of scenarios quickly become intractable. So we had to be quite selective in kind of these hypothetical scenarios we came up with in terms of the magnitude of the disruption, but also the length of the disruption. So I think I've seen some evidence coming out of the number of expected primary screens was reduced by 50% in some settings. But in terms of the US in general, we found that maybe taking these hypothetical scenarios provided some bounds on kind of what we were looking at, though we have been asked repeatedly to be trying to use empirical data. I might just also answer, I think Dr. Franco had one question specifically to the US, and it's a point that I should have emphasized a bit more in the presentation, but we haven't run primary HPV testing alone, although perhaps we should have, just to demonstrate that we generally believe that we can attribute the kind of protective measure, the protective effect of co-testing really to the primary HPV component of co-testing and not really the interaction of co-testing. But perhaps we should be including an explicit primary HPV scenario just to demonstrate that, that protective effect. Yeah, I'll open it up to other.
Thanks, Emily. If other panel members don't want to comment at this point, maybe we can go to some of the questions in the chat box. So Thank you very much. Dr. Eduardo Franco has raised a couple of comments. Firstly, for Dr. Megan Smith, the opportunity to find priorities in management is great, albeit the findings are not always entirely intuitive. In other words, the variation in age. Eduardo, did you want to speak to that directly?
Oh, I'm not sure I understand the entire story. It's a very complex model, and but I love the opportunity to see how we can find priorities, because that's essentially what we need to tell doctors and the actors in screening. So I'm not sure if, age is one of the examples. I could not understand. Also in Emily's presentation, for instance, I was also a little intrigued by the differences between PAP alone versus PAP versus co-testing, and those are also not intuitive to me. I guess it depends on the assumptions and the complexity on the chain of events that are triggered post a positive result. So this is, in moving forward, as you put these models together, some sort of knowledge translation will need to be done, more so than the usual modeling that's done in etiology and in projecting things, because these we're talking about processes of care. So it is, I think you're one notch up, more complex than the 20 years of science on modeling that has existed in this field of HPV and cervical cancer prevention. Models are way more complex now because they imply additional things and suppression of activities rather than addition of things. So it's just that, for someone who has been a consumer of your models over, a couple of decades or more, and I thought that I was reasonably comfortable with the framework and all of that. But, I think as you move forward in submitting these things to journals, there needs to be some sort of digest of how you put them together.
Right.
That's all I want to say.
I think that's well noted, and I think, Megan, if I could reiterate the point that you made, that I think the models are capturing a range of complex effects, and in fact, the findings out of these models are not necessarily expected by their designers. They're quite often counterintuitive. For me, the age effect, which was, I think, strongest in the situation where the woman's last screening test was cytology, I guess, after I thought about it, made intuitive sense, in that we know that shorter screening intervals are required in younger women with cytology-based screening. And I think the corollary of this is the idea that HPV-based screening actually will lead to, in fact, in countries that have transitioned, there's a sort of inherent resilience or robustness, actually, that countries will benefit from, because women are adequately protected for a long time, 5 years or more. So I think that there's a lesson there maybe about the transition to HPV screening in high-income countries, and how it actually will protect women for longer periods of time, and help manage resource constraints once that transition is effected. So I guess on that point, I suppose after thinking about it, I can rationalize it in my mind intuitively, Eduardo. But I agree with you in general. These models are capturing so many complex effects that it's difficult to translate sometimes. Mm-hmm.
Yeah,
Freddie,
I would.
Go ahead.
Sorry, I was just going to echo what Karen was saying in terms of the results were actually a surprise to us. We did this very, very quickly for the Australian government in about April. I was surprised that the effect was so large in women in their 30s in Australia, but actually it was really putting them alongside all of these other countries and seeing the effect in those settings was even larger. Than I think probably the vaccine is protecting women in their 30s in Australia compared to how things could otherwise have been, but it's still not enough. There's all those other sort of vulnerabilities, as Karen mentioned, around less protection or shorter duration of protection from cytology.
I had a question, maybe I suppose I'm a panel member, but I'd like to ask a question anyway to the panel, if I may. I mean, just in view of the disruptions, I mean, you may know better than me. Just thinking about Indigenous peoples in North America, Australia, New Zealand. I mean, where are we with research on the differential impact on services available, taken up by Indigenous peoples, and corresponding outcomes? Has there been much work on that?
It looks like Emily's going to respond. I'm happy to to jump in. I mean, I think I will say from the modelling consortium perspective, it's very much on our list, because what we actually expect, of course, and the great fear is that these disruptions will in fact exacerbate existing inequities and outcomes. And unfortunately, there's reason to expect that will be so. And I think modelling again will help quantify the worst case impact. So I think in terms of actually what's happening on the ground in countries, it's a very mixed picture. I mean, I think in high income countries, we have a range of efforts going on to make screening via HPV self-collection available to priority populations and high-risk populations. But there's different stages of implementation for that type of work. And speaking in terms of my own country, Australia, I think that again, the hope is that the silver lining will be that all of this will actually rapidly accelerate the mainstreaming of self-collection in a high-income country organised screening program. And in fact, our government is now pushing through to get the regulatory and reimbursement aspects of this sorted out through next year towards actually introducing mainstream HPV self-collection in the program over the next year or so. And that's really driven by concerns about those priority populations. So, I think that we will see that type of push more and more, but as many here know, there are a range of in fact, regulatory challenges and validation type challenges that need to be dealt with in terms of sampling for self-collection and its mainstreaming.
Okay. I've got a few questions actually coming up, so maybe we'll just also go to those if we may. There's one that's just come in. Start there from Dr. Stanley. I guess to our Australian colleagues, but it could be for everyone. How do you allow for the impact of vaccination on the women in their 30s in Australia?
Well, I ask this because Australia has such a high vaccination coverage, and that since it started back in 2007, it's not entirely surprising that you're seeing the impact of vaccination, I think, on the older cohort, which wouldn't have had such a high coverage, but enough to make an impact. I think in policy terms, that's really going to matter when you come to looking at other measures you're going to put into the population, and if you're going to use age as a risk group. So I'd like a comment from Karen.
Sure, I'm happy to kick this off, and I'm sure Megan would like to add to it. Thank you so much, Margaret. That's a great question. I mean, I guess the first part of the answer is that the models are complex. All of the platforms that we've been talking about do capture the joint effects of screening and vaccination, and they capture them in a sort of multiple cohort manner. So we are reflecting the cohort level exposure to vaccination with full modelling of herd immunity, as well as those cohorts aging into the age where they're being screened and those effects over time. So that is accounted for, and I think that that kind of concept of the aging vaccinated population in a country like Australia is really one of the big things that has driven the transition to HPV-based cervical screening, and the fact that we're using partial genotyping for 16-18 in the screening program, because the whole concept was that even though the population has been exposed to vaccination, obviously, particularly in the group that were vaccinated at an older age, not as pre-adolescents, that there was a possibility of exposure. And so the idea is that the screening program is designed to complement vaccination, to identify those that are 16, 18 positive, refer them straight on, whether or not they're in a cohort that have been vaccinated, and without having to know an individual woman's vaccination status. So in those terms, everything is explicitly captured. And obviously what's being captured there also is clearly the reduction in prevalence over time in 16, 18 related infections. And eventually, of course, as non-available vaccines start to roll in future, in terms of the age of women who have received them, that will also be captured. Yeah, so, but again, that's kind of the background then to this scenario modeling of then what happens when those programs are disrupted. And I guess I'd say back to the point we were talking about earlier, in Australia, we transitioned to HPV-based screening 2 years ago. And the most recent National Register data shows that I think it's 54% of eligible women had been screened with HPV at the point of crisis onset, which means that more than half of the women were then discharged back to 5-yearly screening and are essentially protected because they were HPV negative, which is the good news. The bad news is that the remainder of women are now overdue for screening and likely to be higher risk. So I think our efforts are really going to be around modelling prioritisation of screening services in that group and then the follow-up in that group. But Megan, you may want to add to that.
Well, I think just probably to reiterate what I said before, I think the 30 to 39-year-old age group looks big in Australia until you see how much bigger it is in every other country that we looked at. So I think the vaccine clearly is having an effect, would be my inference from
that was really, I think, the basis of like just looking at it. You can see the impact of vaccination, whereas in the US, where you're 50% of the population max vaccinated, you're having a much bigger lump in that older age group. So it's good news in some ways, but there's a long way to go.
Mm-hmm.
Okay, maybe try and, I've got 5 minutes to try and get through a few more questions. Karen, if you agree. This is from Narendra. Are there examples of self-collection program strategies and how much is a disruption in such scenarios for self-collection? Anyone? Karen, you're going to have to speak again, I think.
That's a really tough one to answer. I mean, I'm sure perhaps others could contribute. I suspect it's a really heterogeneous picture. It's, you know, it's, I mean, by itself, that's a topic that we could usefully probably do a survey on, isn't it? You know, efforts to introduce self-collection as at the beginning of 2020, and actually now what's happened to those efforts through the year due to the pandemic. I don't know that, certainly I don't feel I have a concerted overview of what's been going on there, and it's probably something that would benefit from some work. And maybe the WHO ICO group, I don't know if Leah and Sylvia and Xavier can talk to that, and whether that's being picked up in any of your overviews. But I think it's a really good question, but very tough to answer.
I do want to. If I may say something about that. Yeah, the information we have in areas where self-sampling had been taken place is that there has been as well a disruption of the collection and distribution of kits. I don't know what has happened in Europe. In Spain, we have a trial and it has been disrupted. I think the issue is that things have not been planned to be for self-collection massively, and that may change in the next coming months in some countries. There's a big effort now in the US to move towards self-sampling, and there is a big discussion, public discussion, FDA evaluation, and I think it will be its introduction will have to be accompanied by specific actions, no, and special programs.
Okay, I'm hearing from Dr. Versters, we've got another 10 minutes. Is that right? We can continue?
Yes, yes, please. I think with all these experts around the table, we should really maximize the output, and there are some issues that we can further discuss. I think for self-sampling, and I just saw that Mark Arban entered the meeting, but he will present later on self-sampling. So I think it would also be a good opportunity to further discuss that. But since I have now the floor, I also had one remark regarding a quote in the presentation of Emily, I believe, regarding quantifying the number of women who might acquire COVID as a result of a screening related visit. I think we should be very careful when we make that way of thinking, because women that don't get a screening visit, it's because there are no healthcare workers available, or it's decided that it might fuel the epidemic due to extra contacts. So I think we cannot compare the risk of getting a COVID during a screening visit versus what is the impact of stopping the screening. So I think we should really emphasize on the impact of stopping screening, but it's not so relevant to compare it to the risk of getting COVID, because every epidemic is different also in different countries.
Okay, any other comments on that? Then there's other questions I can take if there's no more questions. This is one from Eduardo again, and this, I guess, is going back to the aims of this session and the future of the consortium. Would it be possible to consider the differential impact of the pandemic on the supply chain for different screening tests? For instance, I hypothesize HPV testing will be more affected than PAP because the massive C19 testing, COVID-19 testing efforts everywhere else has diverted supplies, equipment and personnel to that, whereas cytology is less affected except for staff being co-opted for work elsewhere. Any comments from the panel or indeed any of the participants?
Well, just from an LMIC perspective, if we were to scale up screening in these settings, it's likely the demand on HPV testing would absolutely skyrocket compared to what it is now once you include all these countries with these huge numbers of women. So, I mean, I think that's probably going to be a huge factor if we can get screening scaled up in the next few years. Perhaps an interesting step would be to actually quantify from the modelling how many HPV tests would be needed to reach these elimination targets, and start with what the actual demand would be from this country's perspective.
Yeah, I think we had a similar kind of issue when we were discussing this around the high income country group and that work, and sort of saying, well, we can sort of prioritise, but how far do you have to draw the line? How low do you have to keep the tests? And that's, I guess, where we were really interested in some thoughts from people. We had assumed cytology might be less affected because, as you said, it's not a direct test competitor, but staff is an issue. So I think it was all of those. Well, if we knew what the constraints were, we could work to find out the sort of optimal strategies to fit within those constraints. But I guess we would really love to have some discussions about where you think they are.
Well, you heard yesterday from Dr. Polyak about those constraints, and they are likely differential by country. In some countries, the few resources available that existed had eventually to be diverted to the C19 testing effort, which is massive. Whereas in other countries, there's a reserve of that technical reserve in equipment, personnel, that eventually would not be as affected. So this is the sort of thing that goes for sensitivity analysis eventually, how to scale up re-entry in primary HPV testing, which could be different in different countries, and to show the penalty that would exist in delaying that, in restoring that capacity that eventually was diverted to the COVID effort back to the cervical cancer screening effort.
And if I could just say, Eduardo, one of the things that worries me is that, many of us have been spending the last, few years or, up to the last decade, really wanting to ensure there's good communication about the relative benefits of HPV testing versus cytology or VIA in LMIC. And of course, countries, because of the practical and relative ease of implementation of VIA-based screening, have struggled, I suppose, to move to conceive of HPV testing. And it could be that one of the unanticipated impacts here, unfortunately, is that we lose a bit of momentum on the agenda around introducing high precision HPV testing in LMIC. I think that's something to keep our eye on over the next couple of years. Mm-hmm. I can see that Sylvia has put a comment, 2 billion tests. So Sylvia, that's an estimate of the demand. Is that correct?
I think that's the estimation that was given like a bit informally at WHO for the elimination target in the up from now until 2030.
Yeah, we also have a comment from Dr. Kate Cuschieri on retention of cytology staff. Kate, do you want to elaborate on that?
Yeah, it was just a comment rather than a question, being honest with you. When we're thinking about reversion or relying more on cytology, it's a dwindling, well, in certain settings anyway, my experience, it's a dwindling pool of staff, which requires a lot of QC and expertise. So that we need to bear in mind if we're going to rely on it a bit more. So it's a comment rather than a question.
I don't see any more questions. Karen, do you want to wrap this up, as we say? Or?
Sure. I mean, if I could just ask maybe an open question. I mean, I would be very interested in whether anyone here has an opinion about high-income countries that are on the point of, or were on the point of transitioning to HPV. I mean, we saw from Leah Brunei yesterday, you know, a wonderful sort of overview of the situation in respect of the transition from cytology to HPV-based screening. And you know, the picture was essentially that most countries are still in transition. And, you know, do we think that this situation is going to delay that transition? And is that something that we should be looking at modeling? You know, the impact of the delay by itself, in fact, on health outcomes will not be insubstantial, even in high-income countries, even where there is established cytology-based screening. So maybe I could just ask that as an open question. Do people feel that's a real threat, and it's going to be a real impact, and would that be useful for us to look at?
Yeah,
very relevant question.
Yeah, I'm Mario here. So I just mean before the COVID pandemic. So if in high-income countries you rely on high throughput analyzers to swallow the number of the specimens per day, and in pre-COVID time, if you decide to start HIV or hepatitis C or hepatitis B or blood donor transfusion screening or HPV-based screening, you just call the company, and in less than a month, you have one instrument, 2 instruments, 5 instruments, whatever you need. Now, the waiting time for the average instrument, which is high throughput through all actual manufacturers, it's 1 year or 2 years. So I mean, even if you decide now that it's the right time, which is not, we know it's not right time, you cannot obtain any single instrument, high throughput instrument in less than 1 year, even if you are US based or whoever, Bill Gates, you know, you will not get this instrument. There's no instruments at all. And all of them are actually reserved for the COVID customers. So I think this will delay for sure. I mean, it's we cannot imagine high throughput HPV screening without high throughput instruments, and this is now the main problem. So availability of instruments.
Thank you very much, Mario. Could I just actually just ask you a follow-up question to you, because you know, one of the things that we were hoping pre-pandemic was that there would be more and more market competition, and of course we've been hoping for years that HPV testing would get down to something like the $5 US mark per test, and that would be facilitated by intense market shaping over time and high volumes. Do you want to speculate as to how this COVID impact will actually change the market shaping aspect and the affordability of HPV testing?
I think we discussed a little bit this yesterday, why you were in the bed sleeping, because
Yeah,
you
sorry, I
know,
missed
it was late in Australia. We had a whole discussion about this, and we actually we see several opportunities actually in all this crisis, and the main opportunities actually for the part of the market which we are lacking currently, and this is low cost point of care based and really I mean the machines which can be produced, tests which can be produced in high quantities, but not sacrificing on the quality. I mean, it's not like we produce a test which is 70% sensitive or reliable as a high throughput instruments. No, we are looking now, because the COVID actually in COVID time there's the revolution in diagnostics started, which we never had before. And as side effect, we actually decide that we will approach actually actively companies who are now inventing new point of care instruments, new tests for COVID, just to be in the line in post-COVID time that HPV should be the first massive target after the COVID. And this is what we see actually in the future. So the idea that the big players having high throughput machines will actually compete each other, and then on global scale, we will have reduction of the price. I mean, it's not really working well, to be honest. So in each country, however, you can tender, you can receive some substantial reduction in the price if you tender. And if the one country decide to use only one system, then you can have some reduction. But on general level, that we will just spontaneously come to the €1 test, I mean, this will not happen, you know, with the current technology. So we really need completely new innovative technologies, which will be developed or are now developing actually because of COVID. So this is what we discussed when you were around 3 or 4 a.m. in Australia yesterday afternoon. Okay, thank you. Thank you.
Okay. Thank you very much for recapping. Well, thank you for a great discussion. I think we are now over time, and I'm sure that you all would like to take a break, I believe, for lunch. So I'd like to close the session, thank my co-chair, Freddie Bray, and all the speakers for fantastic work. And thank you to you all for your very informative insights and suggestions as to the future work that could be done in the consortium. Back to you. Thanks, Helen.
So thank you, Karen and Freddie, for this nice session.